So this week, I'd like to introduce Fabricio Oliveira, and he's at the Federal University of Sao Paulo, and his focus is on neuropsychiatric syndromes and biomarkers. Fabricio?
Well, thank you very much, Alison. It's a pleasure to be here. I have been following this group for more than 2 years now, and it's a very interesting group. I attend most of the meetings, if not all of them. I can't remember if I missed any. And I'm very interested in these subjects and all the talks that have been given so far. And it's a pleasure to be here to speak about my work. This presentation is on biofluid-based biomarkers of neuropsychiatric symptoms in dementia Lewy bodies and Alzheimer's disease. This is the subject of my postdoctoral fellowship, which ended in 2019. And I have published on one paper so far on this subject. I have published other papers on neuropsychiatric symptoms, but we're still working on future publications, and we're going to discuss what we have so far. So these are my disclosures, but none of them are relevant for this presentation. So the background, behavior features may reflect underlying amyloidogenesis and neurodegeneration in dementia syndromes. These mechanisms are potentially measurable by biomarkers and modifiable by pharmacological therapy. So that's the importance of assessing behavior features and biomarkers at the same time. Amyloidogenesis is a neuroprotective mechanism that starts very early in life. It's a response to oxidative stress, trauma, infection, inflammation, and any aggressive mechanism to the neurons that results in the formation of amyloid beta plaques. And the amyloid beta plaques, which are extracellular, they can cause the accumulation of tau tangles, which are intracellular as well. So the problem starts when amyloidogenesis is excessive or when clearance of amyloid is insufficient. So when that happens, we have an accumulation of amyloid, and this excessive amyloid is what causes the destruction of synapses and furthermore of the neurons themselves. So in Alzheimer's disease, the two main pathological features which are shown in this figure from this review article are the amyloid plaques, which are extracellular, as we can see, and the tau tangles, which are intracellular. So we can see the neuron, which is almost fully covered by tau tangles inside it, and they're really dark because of that. So it's important to have in mind the topography, because tau tangles are intracellular and amyloid plaques are extracellular. In dementia Lewy bodies, the mechanism is a little different. So we have the accumulation of Lewy bodies inside the neurons. They are formed by alpha-synuclein and a few other proteins that accumulate, and they lead to the development of the Lewy body dementia syndromes. The most important of them is dementia Lewy bodies, which usually starts with the dementia syndrome and then evolves to Parkinsonism. But we also have Parkinson's disease dementia, which is a complication of Parkinson's disease because we have a patient with Parkinson's disease, and this patient develops dementia as a result of the accumulation of Lewy bodies in the brain. So we're going to talk about dementia Lewy bodies here. So the main features are visual hallucinations, fluctuating levels of attention, the REM sleep behavior disorder, and Parkinsonism, which is usually a later feature of the syndrome. So these four are the core most important features of the dementia Lewy bodies syndrome. And regarding Parkinson's disease dementia, the difference is because Parkinson's usually starts at least 1 year before the dementia syndrome develops. Several papers have shown differences between Alzheimer's disease and dementia Lewy bodies. This is one of them. This is an example that we're going to show. And we have a few features that can help us differentiate them. So here we have several demographic and anthropometric features. So we see, for instance, that patients with Alzheimer's disease, they lived in urban areas with sanitation more often than patients who had Lewy body dementia syndromes. We don't know why that happens, but we also see that patients with Lewy body dementia syndromes had more history of treated systemic bacterial infections. so that there may be an environmental agent that is involved in the pathogenesis of these syndromes, but it hasn't been identified yet. Another important feature is that systolic blood pressure was significantly higher in patients who had Alzheimer's disease than in patients who had Lewy body dementia syndromes. So this represents the fact that vascular risk factors are more important for Alzheimer's disease than for Lewy body dementia syndromes. Other important features have to do particularly with motor manifestations and functionality. So what we see is that the length of Parkinsonian syndrome is usually, it has a longer duration for Parkinson's disease dementia than for dementia Lewy bodies. So the Parkinsonian syndrome, as I mentioned before, it starts before the dementia syndrome in Parkinson's disease dementia, and it starts after the dementia syndrome in dementia Lewy bodies. Functionality is usually more impaired for patients who have Parkinson's disease dementia than for those who have dementia Lewy bodies as well. So Parkinson's disease dementia causes a lot of functional impairment because of the motor features of the disease. Here we have some different features between Lewy body dementia syndromes and Alzheimer's disease. So for instance, regarding pharmacological therapy, we had no patients using levodopa, no patients with Alzheimer's disease usually using levodopa, but patients with Lewy body dementia syndromes use them more often. It's not impossible for a patient with Alzheimer's disease to use levodopa because patients with Alzheimer's disease also can develop Parkinsonian features. And if they do, they can be candidates to the use of levodopa. A patient can have Alzheimer's disease and Parkinson's disease at the same time. But levodopa is usually more prevalent among patients who have Lewy body dementia syndromes. We also know that functionality is usually more impaired in Lewy body dementia syndromes than in patients who have Alzheimer's disease. So this is usually the result of the motor features, but also of the whole spectrum of features of Lewy body dementia syndromes. And here we have the behavioral features, the neuropsychiatric symptoms for dementia Lewy bodies, Parkinson's disease dementia, and Alzheimer's disease. So what we see is that there is a significant difference among the groups regarding hallucinations, which are more prevalent among dementia Lewy bodies than patients who have Parkinson's disease dementia or Alzheimer's disease. We also have differences for anxiety, which is more prevalent for Parkinson's disease dementia and then dementia Lewy bodies and then Alzheimer's disease, and apathy, which is prevalent in all of them, but it's more frequent in Parkinson's disease dementia, then dementia Lewy bodies, and then in Alzheimer's disease. We also have dysphoria, which is a feature of depression, which can happen in all of them, but it's more frequent in Parkinson's disease dementia than in dementia Lewy bodies or Alzheimer's disease. And it's important to notice that all of these patients, all of these groups, they were paired according to similar cognitive staging. So the cognitive staging is very similar, but the behavioral features are very different among the three groups. So the learning objective of this presentation is to evaluate cross-sectional associations of cerebrospinal biomarkers of amyloidogenesis and neurodegeneration with behavioral features in dementia Lewy bodies compared with Alzheimer's disease and cognitively healthy people. We are based upon this paper, which was published earlier this year in the Journal of Alzheimer's Disease. It's a paper from my group. It's called Associations of Neuropsychiatric Features with Cerebrospinal Biomarkers of Amyloidogenesis and Neurodegeneration in Dementia Lewy bodies compared with Alzheimer's disease and cognitively healthy people. The original timeline of the study was to last 2 years, but we had to add an additional year to finish all the reactions. And the original budget was around $150,000. So we had consecutive outpatients with probable dementia Lewy bodies, according to the latest consensus, which were paired with outpatients with late onset Alzheimer's disease, according to the 2011 National Institute on Aging Alzheimer's Association criteria, and also with cognitively healthy older people. These patients with dementia syndromes were paired according to sex, clinical dementia rating, and mini-mental state examination scores. While patients with dementia Lewy bodies and cognitively healthy controls were paired according to sex and age, considering more or less 2 years. This is a consensus protocol that we used for standardization of cerebrospinal fluid collection and biobanking. It's a protocol from 2009, but it's used until today. The first author is Charlotte Nissen, who is the current chair of the Biofluid Biomarkers PIA of the iStart. And we followed this protocol for all the reactions and cerebrospinal fluid collection and processing and biobanking that we did. So we assessed cerebrospinal fluid concentrations of amyloid, considering amyloid beta 42, which reflects the amyloid beta plex, amyloid beta 40, which usually reflects all the amyloid beta in the brain, and amyloid beta 38, which is more specific for dementia Lewy bodies. We also measured tau, phospho-tau, which was phosphorylated in position 181 in the threonine there, alpha-synuclein, ubiquitin, and neurofilament light. They were all assessed by enzyme-linked immunosorbent assays. We also genotyped these two SNPs, which compose the ApoE haplotype, and genotyping was undertaken with Tachman real-time PCR technology. This is a paper which showed that CSF amyloid beta 38 was more specific for dementia Lewy bodies. It was not reproduced in all papers, but it's an important paper. And ours was the first study to assess amyloid beta 38 in the cerebrospinal fluid by way of enzyme-linked immunosorbent assays in Brazil. This is another paper that is very important. It shows that cerebrospinal fluid alpha-synuclein in Lewy body-like symptoms, they are hallmarks in dementia Lewy bodies, and low cerebrospinal fluid alpha-synuclein is associated with hallucinations and poor executive function. This could suggest underlying synuclein pathology. Associations with memory and language in Alzheimer's disease suggest that reduced alpha-synuclein can partly reflect global impaired neuronal and synaptic function. And this is an important mechanism in these patients, but it's not exclusive to patients who have dementia Lewy bodies. Patients who have Alzheimer's disease can also have Lewy body-like symptoms reflecting the amount of alpha-synuclein in the brain. And this is another paper that shows that patients with Alzheimer's disease can be characterized, can be subdivided according to amyloid beta 42, tau, ubiquitin, and ApoE4 carrier status. So we decided to measure ubiquitin because of the results of this paper. Our biomarkers and the biomarker ratios were associated with hyposmia in behavioral domains of the 12-item neuropsychiatric inventory. It's important to note that hyposmia was assessed because it's an important feature of most Parkinsonian syndromes. These patients can have hyposmia, so we decided to assess hyposmia as well as the behavioral symptoms. These analyses were adjusted for sex, years of education, age, estimated duration of the dementia syndrome, number of ApoE4 alleles, and use of psychotropic drugs. The results were corrected for false discovery rates, and the threshold of significance was set at p less than 0.05. So we had 27 participants with dementia Lewy bodies, comprising 11 ApoE4 carriers, 27 participants with Alzheimer's disease, comprising 12 ApoE4 carriers, and 27 controls, but only 4 controls were ApoE4 carriers. This is expected because ApoE4 carrier status is a risk factor for Alzheimer's disease and also has to do with the pathogenesis of dementia Lewy bodies. The mean scores on the 12-item neuropsychiatric inventory were higher for dementia Lewy bodies than for Alzheimer's disease in controls, particularly regarding apathy and hallucinations. These are the anthropometric and demographic variables of our patients. So we had 3 groups of 27 patients. 2/3 were female in all the 3 groups, so they were exactly paired according to sex. They were similar in age, but patients with Alzheimer's disease had higher education than patients with dementia Lewy bodies who had lower education. This, we don't know why we found this, but you can see that all of the groups had low levels of education. This happens because most of these patients were born in the first half of last century in Brazil. And at that time, higher education was very rare, and most people studied only a few years during their lifetimes. The age at dementia set was similar for dementia Lewy bodies and Alzheimer's disease. And the clinical dementia rating sum boxes was also similar for dementia syndromes, but it was much higher than for cognitively healthy controls who were not impaired at all. The ApoE haplotypes were not significantly different, but we can see that ApoE4 carrier status was very similar for dementia syndromes, but we only had 4 ApoE4 carriers among cognitively healthy controls. These are the behavioral domains. for all the three groups. So we can see that the patients with dementia Lewy bodies had more behavior impairment than the other groups. This behavior impairment was more notable for agitation, hallucinations, anxiety, apathy, delusions, dysphoria, and aberrant motor behavior and nighttime behavior disturbances. So we can see that behavior burden is much higher for dementia Lewy bodies than for Alzheimer's disease, and cognitively healthy controls, as expected, have a very low behavioral burden. These are the variables for ApoE4 carriers. So as I said, we had 11 patients with dementia Lewy bodies, 12 with Alzheimer's disease, and 4 cognitively healthy controls were ApoE4 carriers. We see that there's not much difference concerning amyloid beta variables, tau pathology, and alpha-synuclein among the three groups. But we can see here that patients who had dementia Lewy bodies had very low neurofilament light according to the other groups. This is the table for ApoE4 non-carriers. So we see that neurofilament light was higher for dementia Lewy bodies when they were ApoE4 non-carriers than when they were ApoE4 carriers. But for the other groups, there was no significant difference. We can also see that the amyloid beta 42 over amyloid beta 38 ratio was higher for dementia Lewy bodies and lower for Alzheimer's disease. So this happens because for dementia Lewy bodies, amyloid beta 38, which is more specific, is usually lower. And for Alzheimer's disease, amyloid beta is usually lower. So for Alzheimer's disease, this ratio is supposed to be lower. And for dementia Lewy bodies, this ratio is supposed to be higher. But this happened only for ApoE4 non-carriers. Tau pathology was similar among the three groups, but we had another ratio that was different, which was the alpha-synuclein over amyloid beta 42 ratio. It was higher for Alzheimer's disease and lower for dementia Lewy bodies, reflecting the fact that alpha-synuclein is usually lower in the cerebrospinal fluid for dementia Lewy bodies, who have more alpha-synuclein pathology, and amyloid beta 42 is usually lower for Alzheimer's disease, so they have a higher ratio, and it is reflected in the table. So, summarizing the results, only patients with Alzheimer's disease had mean tau over amyloid beta 42 over 0.52. This is a finding that is very common in the literature because these patients have lower amyloid beta 42 and higher tau. So the ratio tau over amyloid beta 42 is a ratio of quality of the study. And our patients were probably well diagnosed by the clinical features and the cerebrospinal fluid findings. ApoE4 carrier status affected the amyloid beta 42 over amyloid beta 38 ratio and determined similar tauopathy for both dementia syndromes, particularly for ApoE4 carriers. ApoE4 carrier status influenced alpha-synuclein over amyloid beta 42 ratio, but not tau over alpha-synuclein ratio in dementia Lewy bodies. This probably reflects the fact that tauopathy in dementia Lewy bodies is more similar to Alzheimer's disease and less affected by ApoE4 carrier status than amyloidogenesis. So if tauopathy is similar, then this ratio was not affected in dementia Lewy bodies. But this ratio was affected because amyloid beta 42 is usually lower and affected by ApoE4 carrier status. The levels of neurofilament light were affected by ApoE4 carrier status in patients with dementia Lewy bodies only. For Alzheimer's disease, they were similar, but for dementia Lewy bodies, ApoE4 carrier status affected the levels of neurofilament light, as we saw in the table. And isolated biomarkers were not useful to distinguish dementia syndromes in the study, possibly due to underlying amyloid pathology in all participants resulting from their older age, but also potentially due to our modest sample size. So as you could see, our patients had a mean age ranging from 78 to 81 years old. So they were older patients, and this could have affected the fact that some biomarkers were not significantly different among the three groups. So now we're going to see the associations with neuropsychiatric features. So for dementia Lewy bodies, we had a few associations, but the ones that remained significant after multiple corrections for multiple correlations were amyloidogenesis associated with hallucinations, and the phospho-tau over amyloid beta 42 also associated with hallucinations in dementia Lewy bodies. And we also had an association of tauopathy with dysphoria and alpha-synuclein over amyloid beta 42 with dysphoria. And we can also see that measures of amyloidogenesis were associated with more hyposmia in patients with dementia Lewy bodies. For Alzheimer's disease, we found a few different associations. So we had an association of agitation with tauopathy, and we also had an association with nighttime of tau over amyloid beta 42 with nighttime behavior disturbances, and also of phospho-tau over amyloid beta 42 with nighttime behavior disturbances, and also alpha-synuclein over amyloid beta 42 with nighttime behavior disturbances, which seems to be affected by both tau pathology and amyloidogenesis, because amyloid beta 42 is usually lower in these patients. So, in conclusion, biomarker ratios were superior to amyloid beta and tau biomarkers, predicting neuropsychiatric symptoms when associations with isolated biomarkers were not significant, but similar when these associations were significant. ApoE4 carrier status influenced amyloidogenesis and tau pathology in both dementia syndromes. In associations of measures of axonal degeneration, neurofilament lighting, in this case, with neuropsychiatric features were observed only in patients with Alzheimer's disease. So for future prospects, we know that some drugs, they have associations with cognitive decline in Alzheimer's disease. So for instance, brain-penetrating angiotensin-converting enzyme inhibitors seem to be protective over Alzheimer's disease progression. And we can also try to establish associations of biomarkers with the use of angiotensin-converting enzyme inhibitors in the future. There have also been a few papers showing that angiotensin-converting enzyme gene variants, they can be associated with monoamine metabolite concentrations in cerebrospinal fluid. So other significant associations might also be found. I'd like to thank our sponsor, the State of São Paulo Research Foundation, the Agreed Dementia. I thank you for the invitation. I'm very happy for being here. And I'd like to thank my colleagues at the Federal University of São Paulo. So thank you very much. And I'd like to thank Anvita and Malavika for the technical assistance, and Alison for the eternal friendship. Thank you very much.